everybody. I'm Nina Crowley. I'm Seeka's professional affiliations and education manager, and I'm here with Kelly Broadwater, psychologist and certified eating disorder specialist. So thanks for joining me, Kelly.
Thanks for having me.
And today I'm really excited because you and I are going to both be at a conference together, the Obesity Medicine Association meeting in Texas, and we are going to be able to reconnect. And I'm going to get to hear you speak on a topic that I really think is, doesn't get enough attention, sort of the intersection of bariatric surgery or higher weight patients and eating disorders. So you definitely are the specialist in this area, and I think everybody's going to really enjoy your talk. I'm really excited.
Yeah, I'm excited. I've never been to OMA, so this will be my first time.
Yeah, it's a great meeting, and I think they'll all, we talk a lot in the bariatric surgery realm, and now we're seeing so many more patients who are on the medication. And medications for obesity, and so I think we're really going to have interest in people, needing to know what to do where this crosses over. So yes, I want to hear about your talk, but first I wanted to hear, kind of share how you and I know each other through the bariatric realm. And you're in North Carolina, I'm in South Carolina, and share the exciting news about your new book. So this was something I got to kind of dive in and look at very intimately.
Yes, you did.
and write the foreword for it. So tell me, a little bit about the book and how people can get it.
Sure. The book's called BariEDucated, and it's got a long subtitle. I usually have to look at it. So here's the book. It's an integrated health guide for dietitians and behavioral health specialists caring for bariatric surgery patients, which is a mouthful. But BariEDucated, we capitalize the ED and educated for eating disorders because so many bariatric patients either have eating disorders preoperatively or relapse postoperatively. And being certified eating disorder specialist, me and my co-author definitely have worked with this population for a long time. So we wanted to devote a good portion of the book to that and kind of bridge the gap there because bariatric professionals don't typically know about eating disorders, and eating disorder professionals don't get a lot of training in bariatrics. So we're kind of
I think it's such an important topic because we don't get that training, but then patients tend to stay with their bariatric program, and then they really need to know how to bridge that gap, who to go to when they're seeing something. As a dietitian, we would always see sometimes the first inkling of there being an issue, and knowing how to get them to the right treatment, I think, is important.
Yeah. I think medical and dietitians are kind of going to be the first people to probably identify it if they are looking for it and asking.
Yeah. Well, great. So obviously, doing a lot of research and a lot of work on that book. Now you're able to sort of take that and present about, similar issues. I know we've had you at the North and South Carolina bariatric chapter meetings. I think, your approach with Chandra, dietitian, psychologist combination is really nice. So tell me a little bit maybe about what your talk is going to be about, a little sneak preview.
Sure.
If you can.
Sneak peek. So I'm talking about disordered eating and eating disorders in higher weight patients, not just bariatric surgery patients, but in the obesity medicine realm, certainly, eating disorders, higher weight patients are the most likely to have an eating disorder, which is something that a lot of people, I think there's a common misconception. We think eating disorders, you're thinking, anorexia or bulimia, but the majority of people with eating disorders are higher weight. So being able to identify it, especially as more and more people are going to be seeking, medications, making sure they're appropriate for the medications and not dealing with a kind of rampant eating disorder. Obviously weight management can be trickier with somebody with an eating disorder. You really want to resolve those issues first because they can be so medically dangerous if left untreated. So hopefully, I know I'm going to be speaking to a lot of medical doctors, which is, I'm not one, but hopefully I'll be able to give them some good guidelines of things to look for and ask about.
Yeah, and I think too, we know in bariatric surgery that the interdisciplinary team has been around, and that's been a strong component of, we have to have that for our standards, but I think there's less often structure around a medical program, there's not a required behavioral health person on that team necessarily, or even, maybe a dietitian or an exercise professional. So, so are you going to talk to them about, how to spot stuff? Are there screening tools, or
Mhm.
what kind of resources do you recommend?
Yeah, I'm going to go through screening tools, questions to ask, labs to draw, kind of the whole shebang, and then how to get them to appropriate treatment. So obviously they can be like, this may not be my wheelhouse, but how do they, you connect with dietitians and behavioral health specialists that do treat eating disorders. So
So at the outset, like before someone starts on medication, is that really a big focus, or is it during?
anyone that kind of walks through their doors that is seeking weight management, kind of doing the background check, kind of are they dealing with something else that could interfere with their success, or make it dangerous for them
Hmm.
to proceed. Um,
How does that usually present?
I mean, it's one of my takeaways is it's not one size fits all. So, but somebody that's got like a long history of weight cycling. I mean, are they engaging in binge eating disorder? Are they engaging in restriction to the point that it's atypical anorexia? I'm going to talk about both of those primarily
Mm.
in terms of the eating disorders, and then disordered eating. Exists on a spectrum, and most people have
Right.
some type of disordered eating, but being able to kind of know when it's crossed over to problematic and what to do about it.
And that I think, that we're not using, like you said, just weight as the criteria of, oh, well, clearly they don't have anorexia. I've heard people say that,
Right.
about someone in a larger body. So I think that's important too, looking beyond just someone's weight, right?
Absolutely. And atypical anorexia is um, getting more attention. It's not its own diagnostic criteria yet. It's under other specified feeding and eating disorders, but I think eventually it'll be in the DSM as its own because we're seeing more and more of it. So, for
Mm.
example, in my practice, I had a patient that needed to be in our intensive outpatient program for eating disorders. And she was the highest weight of anybody in that program, but her labs were the worst in terms of
Mm.
malnourishment. So she would come into my office and say, I don't really belong in that group. I don't fit. I'm the heaviest one in the room. Everyone in there is sicker than me. And, of course, HIPAA, I couldn't be like, no, girl, your labs are the worst that, of anyone in there. But she was
Mm.
definitely restricting very heavily and had significant signs of malnourishment in her lab work. So
Mm. This was a post bariatric patient?
mm-hmm.
Yeah.
Yeah,
Well, and I'd imagine that's hard too to figure out, right? Like what's the normal amount of restriction and what's more, problematic. And
sure.
obviously that's what you're good at figuring out. And the behavioral component of that is so nuanced, right?
Yeah, absolutely, because the procedure itself requires you to be restrictive in your eating, but there are nutritional guidelines and what you need to be getting in, and she was definitely not meeting those. I mean, she was
Hmm.
restricting to minimal calories and having issues even with like passing out and pretty significant deficiencies.
Gotcha. Well, and thinking too, about the medications, I think this is a lot of the media that we're seeing about the anti-obesity medications, the semaglutide, and those GLP-1 receptor agonists. Is that a lot of times people aren't hungry, and a lot of times it's an interesting balance. I think when people are saying, "Well, great, I'm not hungry," that was my problem area. It was having too much hunger, and but knowing that there is supposed to be some hunger and awareness of fullness and satiety cues. And so I'd imagine for this group at OMA in particular, that's going to be how do they pick out this part of it, right?
Right. Yeah, and I mean, even though you're not hungry, you still have to nourish your body. So making sure you're collaborating maybe with a dietitian that can and help that patient follow an
Yeah.
appropriate
I'm
plan.
thinking too in the way that the access to care issue has kind of really affected the medications, that a lot of times patients are coming in kind of seeking like this is what they want. This is, they're presenting, kind of a little bit differently than with bariatric surgery, but they're presenting saying like, here I am, I want this medication. Can you give it to me? And without assessment or like a required psychology evaluation, like we had with surgery,
Mhm.
what do you do in those situations?
What we're trying to do here is partner with doctors in the area and letting them know about our services because, I mean, you know, they're not all going to require someone to come our way, but
Right.
if they're kind of suspect that somebody's dealing with kind of a deeper issue or needs more coaching and support in terms of the nutritional piece of things. So,
Mm,
really an integrated health model, right? It's
right.
ideal.
So how though, in a patient, again, I'm just thinking out loud here, a patient who is sort of self-presenting, like people, because people know, right, like what behaviors are problematic and they might not want to disclose if they're
Sure.
seeking additional weight loss. And is this medication gonna, help them reduce their body weight if that's really what they're after?
Yeah, and I think one thing that we've had other practices in town have different weight management programs over the years, and they would identify people that were not being successful with weight loss, even though they were doing whatever the program was, and so they were like, "Huh, maybe there's more to this." So it could be a matter of they're prescribing and somebody's not having success on it.
Mm,
What's that about? That yeah, I think it's going to be an interesting to see how this all plays out with AOMs in the long run. With how do we best identify folks?
yeah. Well, it's a tricky place to be, right? We want to get the medication that's very effective to the right people, but we
Hmm.
don't want to add layers of, barriers like evaluations if they're not required, right? But, I think I think you're doing the right thing, sort of equipping the people who are at that decision point with some tools and with things to look out for, right?
Sure.
So, I mean, do you have any tips that you can share? What should they be looking at? Like, what are some of the, phrases that they can look at in a patient's language, or things that they're seeing for maybe a new person or somebody who's already on the medication and maybe it's problematic, they need to titrate it down, or
Yeah, I mean, I think even just asking them what they're eating like in a typical day, kind of getting an assessment. I know, again, they're not dietitians, but they can kind of be looking for some risk risky words or risk factors of like, yeah, well, I'm just not eating all day long, or I'm feeling dizzy in the middle of the day because I haven't eaten, or you know, or asking, what kind of side effects are you having? Are you making sure you're getting enough nutrients to fuel your body? You know, really, if somebody's acting phobic about food or weight gain, you want to kind of ask more questions. And so I have kind of a whole list in the talk of questions to ask folks. And I know medical doctors don't get a ton of time with their patients, but I give some basics on like screening tools and questions to ask. And not everyone's going to get caught proactively. Some of it's going to be,
right.
oh shoot, this has become a problem.
And I'm thinking too, are you looking more for restrictive type eating in this population, or um, what are the
Restrictive or
other?
binge eating. If they're on medication, that's not a cure for binge eating disorder. And one of the kind of the big misconceptions about binge eating disorder is that people are just eating huge amounts of food all the time. A lot of times they're restricting most of the day, and then it's kind of that letdown of like, okay, I haven't had enough, and then or they restrict purposely so that they can binge. It presents itself in lots of different ways, but a lot
Mhm.
of times it is that there is an element of restriction, and then that restraint gets released, and it's kind of off to the races. So
Mm. Well, you bring up a good point, and people thinking, I know that was a big misconception with surgery was, oh, well, this is a cure or a treatment for binge eating. How have you seen that kind of interplay with the medication realm? Are people thinking that is a cure? Is it changing the binging
So
frequency or anything like that?
they know from me it's not a cure. So I have kind of a biased view of it, right? Where if I have clients that are choosing that option, we're really talking about that in depth before they make that decision.
Hmm.
So I'm kind of, the exception versus the rule, because a lot of people are going to be going to their doctors first, not talking to their eating disorder specialist first. So
Right.
um, I don't have a great way of answering that for.
Yeah. Well, no, I'm just thinking that the education component I think is big, and
Mhm.
this group, especially with the medication, the doctors who are prescribing that most, they'll probably have some good feedback about, what are they seeing in their patients,
Absolutely.
and I mean, I'd imagine too that for binge eating, um, in particular, there probably is some impact of the medication. Not saying it would be used in that population for a treatment necessarily.
No, I think it maybe in conjunction with.
Mhm.
I wouldn't necessarily recommend it. I don't recommend anything before
Right. Counseling and
counseling and nutritional treatment.
yeah.
But it could be a tool in the toolbox down the line if they're in a better place with their eating disorder. You don't want somebody who's active in their eating disorder necessarily diving first into either surgery or AOMs.
Is it considered a contraindication for medication? I don't know that I've seen that.
I haven't read, it'll be interesting to see how it all, I mean, people in the eating disorder space are, you know, typically very anti anything weight loss or weight management.
Okay.
I have a kind of a more balanced view of that. Um, but it'll be interesting to see as it progresses what comes out about that. Yeah.
Hmm. Yeah, I think those are, and just to your point, there's not a lot of people who are expert in both. I do think that there are, a lot of loud voices out there against, treating obesity even. And I think a lot of that comes from folks with a history of um, eating disorder backgrounds too,
Mhm.
you
Yeah.
know?
Yeah. I would say that there's bias in our profession.
Hmm.
So I one of my favorite slides that I did is on the overlap between obesity and eating disorders and how they're both, complex chronic diseases. They're both subject to a lot of stigma and misconceptions, and they both require multidisciplinary care. As kind of some of the highlights from that slide. I don't remember all of it.
Okay.
I will by Saturday, right?
Well, I think too, a lot of times we come back to this interdisciplinary care team, right? So I think that's, to me, one of the big take homes is if you're, working with patients who are on medication for obesity, you've got to assemble the right players. And I know from my background as a dietitian, that's really important. And,
Absolutely.
as a psychologist, I think that's also a often overlooked component in a proactive way, but really getting that team together so that you can treat all the types of people who come.
Yeah, I mean, multidisciplinary care is the gold standard for treatment of eating disorders. I think it's, in my opinion, the gold standard for treating obesity as well. And I can't imagine being on a medication and not having nutritional support, but I know that's not necessarily the norm yet, hopefully.
Right. Right.
Um,
Yeah. And yeah, I think that's a big take home, and probably where we're going to see moving forward. The longer people are on medications, and sometimes they struggle with weight recurrence, and that is another kind of trigger, I would say, for needing that interdisciplinary team to really work through some of those issues. And I think we're just going to see that the longer people are on medication for longer
yeah.
term, just like a lot of the lessons that we have with the surgical population. I think we really need to apply the model that works,
Mhm.
to the medical realm. And I think, I, I know you probably agree that we're seeing a lot more collaboration amongst, it used to be very medical, surgical, siloed
Mhm.
care, right? But I'm seeing a lot more overlap, and people are kind of flip flopping from maybe they're a surgical patient who needs medication, maybe they're a medical patient and they end up needing surgery. So I think that will help as well.
Yeah, absolutely. It does feel like I've been in, this space for 20 years. So bariatrics was newer when I first started. And so seeing kind of the evolution of what we know and how we treat, I think it'll be the exact same thing with GLPs.
Getting that team together. So,
Yeah.
well, good. Well, your book will be the right manual for people who are getting involved in that space too. Then I'd imagine, right?
Hopefully. I mean, it was interesting. We wrote the book in our free time. So, um, when we were writing it, I mean, AOMs weren't nearly as all over the place as they are now.
Mm.
We weren't seeing any patients at the time that were on them. So we don't speak to them in this edition, maybe in the next, if we
But
get
the skill
ambitious.
set, I mean, the skill set and the behavioral component are likely the same
Sure.
or close, right?
Right. And the way to assess is the
Hmm.
same. So,
Yeah, so some
but the book
parallels.
doesn't speak necessarily to the medications because, like I said, we they weren't widely prescribed when we first started.
Okay, well, that makes or not a revision, a version two
Yeah,
needed.
second edition. We've already
Second
started
edition,
notes
that's
of
it.
like, oh, we got to add this. We got to change that, update this.
Gotcha. Well, great. And well, I'm looking forward to hearing your talk live. And if is there anything else you want to share, just so that people have some take homes and things to be looking out for?
Let's see. Well, I mean, I think one of the things that I always emphasize in any talk I give is that eating disorders, um, they now have the second highest mortality rate. For the longest time, they were number one, but we're
Mm,
surpassed by opioid overdoses. But if any mental health condition, we've got a really high mortality rate of about 20%. So
okay.
it is important to be screening and sending people for appropriate treatment.
That's good advice. Yeah, I didn't realize it was that high.
Yeah.
Hmm. Okay. Well, thank you so much for your time today.
Not
I
to
think a
end on
lot
a
of,
sour note. Jeez.
right? But a lot of valuable
Post-traumatic
stuff.
factor, people will die.
Well, I think, kind of emphasizing what role someone can have in preventing that. I think that's really important.
Absolutely.
So, all right. Well, thanks, Kelly. I'll see you soon and appreciate you.